Now, if you can tie this all in, what we're going to be looking at, as you can see on our second slide on the first page, is the central nervous system. We're talking specifically about the brain and the spinal cord. What we're going to be doing after that is really just describing some of the function. This is all we're really looking at in terms of the central nervous system being all the inner neurons. So it's going to be receiving information from sensory neurons, whether that's coming in from the special senses, the eyes, whether that's coming in from proprioceptors, and we'll talk about that especially in our sensory lecture. These are things that are telling us our position in space, telling us what the joint angle is, the amount of muscle tension in this particular area, what position I'm in, what muscle tension is found in certain muscles. All that information is giving us information about our body, as well as external information of what's happening on the outside environment. We've got all these receptors sending information in. That's the afferent pathway into the control center. And that integrative center, the integrative center with all those functions, whether it's thinking, decision-making, memory, perception of sensory information, processing of sensory information, is all taking place in the integrative center. And that's exactly what we're looking at in the in the central nervous system, that it consists of all these inner neurons that are going to be receiving information and processing it. And then, as the central nervous system, the inner neurons that are located in the brain and the spinal cord, they're going to now send information back out the efferent pathway. And the efferent pathway in that case are going to be those muscles. They're going to be the neurons and the glands that are going to be taking part. So we're going to be illustrating the pathways that are taking place in the central nervous system, just looking at those inner neurons. So as you can see in the bottom slide on the embryonic development, I'm just going to talk a little bit about this because the idea really isn't so much about what's happening in the embryo. What's taking place at the point at which an embryo develops is the rise of three different different germ layers. These are different layers of the cell that we're looking at. There's an ectoderm, there's a mesoderm, and there's an endoderm. You don't really need to know that, so don't worry about that portion. But what you're looking at is when we look at a whole cluster of cells, they start to divide, and they're rapidly dividing. And as you look at the sphere that develops, look at a whole cluster of cells that just look like this. They're just rapidly divided, and it's a whole sphere, ball of dividing cells, that's eventually going to give rise to the developing fetus. And at that point in embryonic development, there's different phases or different layers that will start to form as differentiation starts to take place. At some point, we have to establish polarity, meaning some part's got to be the head, and some part is going to have to be the anus, right? At least the one portion and then the other. So what's going to happen is you're going to see on that particular slide, on that bottom slide, is that we start to see the rise of the ectoderm. And the ectoderm is one of the layers that becomes the essentially the central nervous system. It's going to start to create the nervous system in its whole, and I'm getting there. There we go. It's going to start to create these different layers. So here's our sphere that we we're just talking about. Now it's going to start to differentiate and create different layers where you have an ectoderm, an endoderm on the inside, and a mesoderm right in the middle. And what's happening is that we're starting to give orientation to the fetus, where a certain part is going to be the head end, and the other one's going to become the tail end. And that's going to create one part, it's going to create the brain, and the other part's going to create the very bottom portion of the spinal cord. So what's happening at this point in time, and here you're seeing from a transverse view, just a cut right through the center, you'll see the folding of the ectoderm. And the ectoderm starts to fold where we start to see this portion right here. We create these neural folds, and then we start to see the arrangement of the neural tube. So what we're doing in this particular layer is we're creating a layer that becomes a long tube. So now if we take a look at that tube and take a look from the top portion of it, here's that view of that tube, that blue layer that starts to form. You see the formation of that plate, and then it wraps around and it's supposed to fold in itself to sort of create like a little tube. Okay? So as it starts to fold, you'll start to see areas of which this area starts to become the spinal cord, and this part becomes the brain. So if you take a look at the development of the fetus, you should see that these should fold all the way from the very bottom to the very end. Have you ever seen anybody with spinal bifida? Spinal bifida, you'll notice that they have very underdeveloped legs. In fact, their legs don't even really function. And that's due to the incomplete closure of the tail end. That plate doesn't close all the way, and that becomes underdeveloped. Essentially, if there's no central nervous system, meaning the spine isn't fully closed, then the legs don't work. Now, if you get incomplete closure of the head, well, then the brain doesn't develop, and then the fetus is ejected. So looking at that, if you were to take a look at that tube, we've got this tube that's laid out for us, and we're looking at a bird's eye view of it, we're going to start to see that certain areas, particularly the head end, is going to start to develop a lot faster than the rest of the tube. And we can see this as the embryo starts to develop. Here we see about 3 to 4 weeks. We start to see about 7 weeks, 11 weeks, and eventually an adult brain. And what we're looking at is a regional specialization. We'll start to see an area that becomes the spinal cord, which is the tail end, and we start to see what's called the telencephalon, the front area, which is the head end. And as you notice, when you start to take a look at that embryo, as it starts to move through, you'll see that one area, specifically, you'll see in the book, it's called the forebrain, or the telencephalon, will start to develop much faster than the rest of that tube. The rest, earlier, you'll see the other tail end becoming the spinal cord, and this creates that profound development. So looking at from the side, from a lateral view, you can see that the telencephalon grows much further, and I'll show you that on the next slide. This piece right here, this particular slide just shows you the formation of, that won't work because I'm not connected to the internet. Connect to the internet real quick. So this should load up in a second, and if it doesn't, that's okay, because I'm going to give up and move on to the next slide. It's not really important, don't worry, it's not going to be on the test. So here we're looking at that tube, right? We see that tube, that neural tube that formed, and what we're going to be looking at as that embryo starts to develop, you'll see that the telencephalon is the one that is going to give rise to become the brain that we would see, the adult brain. So this area is going to grow faster and faster, and that's something particularly interesting about embryos. If you look at embryos as a whole, and this is where they take a look at specifically embryonic or at least developmental physiology, you'll start to see that embryos of many species look the same, especially early on. But what gives rise to primates especially is that the increasing telencephalon. This starts to grow faster and faster compared to the rest of the areas. And so areas of the spinal cord, the hindbrain, which is going to be the cerebellum and the thalamus, the midbrain, which is going to include the hypothalamus and areas here, these are going to be more of the primitive rat brain. And they're going to be more responsible for autonomic functions. Things like the heartbeat, respiratory rate, and so forth. The other areas, the telencephalon, that's going to give rise to the actual cerebrum, the bigger part of the brain, are going to be the higher mental functions that'll take place. Our capability of analytical capabilities, our conscious thought, and other higher level functioning. And so what we're going to be looking at next is just the telencephalon, how it grows. You'll be able to see on the next slide over, that same tube, not only are you going to see the regional specialization where you see the telencephalon growing faster, you can see that there's also lateral growth. Here you can see the left side and the right side. So this is going to give rise to the different areas of the brain, the left hemisphere and the right hemisphere. On the inside, you'll see that this is the tissue. Here's the space on the inside that's formed as a result of that tube forming. And that space is going to start to fill up with cerebral spinal fluid. We'll talk about that in the next later. So while we see growth of the telencephalon, we see the lateral sphere starting to grow. Here we can see the rise of what we're going to be looking at. So what you saw earlier, the blue part of the tube being the hindbrain, you're going to see is the cerebellum and the thalamus. We're going to see the yellow portion, which we saw, which is the midbrain, which typically is the brainstem. And then the biggest red portion is going to be the telencephalon, and that is going to be the cerebrum that we're going to be looking at. So now that you have an idea of how the telencephalon or the cerebrum is going to start to grow, the bigger areas of the brain, let's take a look at some of the other brain protection mechanisms for protection. And here you're going to see the meninges. And the purpose of the meninges is to serve as an outer protective layer for the brain. Of which, if you were to take a look at the meninges, you'll see that there are 3 specific layers. If you see the term meninges, you've probably heard the term meningitis. I know there was a question asking about meningitis. Meningitis is just an inflammation of these protective layers. Okay? It's a viral infection that comes in and can eventually make its way in. And there's a lot of concern for those viruses to eventually make their way into the neurons, so they can eventually start to destroy them. But typically, they only penetrate up to the outer layers. If you take a look at the layers themselves, you'll see that we have 3 main layers: the dura mater, arachnoid mater, and pia mater. And of which the term that you will see that's common amongst all these is mater. And that translates in Latin to mother. So the outer layer, the dura mater, bless you, dura mater, the durable mother, is the hardest layer of the outside. If you ever look at any dissection videos, and if you take a look at the brain, there was an outer layer that was the hardest portion. And you'll see that we have, with the dura mater, actually broken down into 2 separate layers, of which we have the endosteal layer, which is connected to the skull. You have the dural sinus, which is just a space in between the 2 layers. And then you're going to get the innermost layer. And this is going to be the meningeal layer. This is the layer that's actually almost close to the brain. If you take a look at the arachnoid mater, the next layer down, arachnoid mater, spider mother, you'll notice that the arachnoid mater actually has these trabeculae, which are these structures. And that allows things such as cerebral spinal fluid to flow through, which we'll tie in just a bit. And then the pia mater. Pia mater is actually, pia standing for soft. Soft matter. This layer is going to have direct connection, or directly touch the actual brain tissue itself. So it's going to be the layer right over. And what that's going to do is going to have all these capillaries that are going to come in and provide nourishment for the neurons that are right up on that brain. And so what you're going to be able to see of all these, again, if these were the outer layers, you'll note that on the inside of the brain, we're going to also have that space, that same space that arose from the inside layer, from that neural tube. And that's going to fill up with cerebral spinal fluid. So taking a look at the 4 ventricles, those spaces that we talked about, the arrangement of those spaces, you're going to see we have 4 ventricles. Again, something that you already learned in anatomy. We have the lateral cavities over here, the lateral ventricles. We're going to have the 3rd ventricle on the inside, which is going to be right by the thalamus. And we're going to have the 4th ventricle, which is going to be the ventricle out over here. And that area is going to be right by the brainstem and right in front of the cerebellum. So these areas are going to allow fluid to flow through. And where's that cerebral spinal fluid created? We know we're going to have what's called the choroid plexus, which is a whole bunch of tissue that consists of ependymal cells. And these are the cells, if you remember, as we mentioned. On the apical side, we're going to have cilia. And this is a single layer of either cuboidal or columnar epithelial cells that are going to be secreting stuff out into the lumen. So they are exocrine epithelial cells in that they're going to secrete out to the outer layer, and the cilia on the apical side are going to help brush that cerebrospinal fluid out. And you can see where that cerebrospinal fluid, if you take a look at the characteristics of the spinal fluid, it pretty much is very similar in composition to blood plasma. In that here we have a capillary that comes in, or specifically a blood vessel that's carrying blood. You're going to have our ependymal cells, which are going to have tight junctions in between. And they're holding very tightly so that things that have to that leave the blood have to flow through those epithelial cells. So they help govern and protect what's happening on the outside. And then as that blood flows through, now you're going to have what's called that blood-brain barrier. You have fluid coming back out, and that fluid is going to serve many functions, of which we're going to see mechanical protection. The brain is literally just bathing in cerebrospinal fluid. Okay? So you have this fluid on the outside that helps absorb shock. Not only that, you'll also see that the brain, specifically the cerebrospinal fluid that's flowing through, is our direct pathway to tell us what's actually in the blood itself. So if I've got a bunch of acids in this area that's flowing through, acids such as lactic acid, that is as a result of anaerobic metabolism, as a result of glycolysis. So lactic acid starting to form in that area. Now, here you see that the blood, as the blood is flowing through those capillaries, we'll note a certain area called the medulla oblongata, which is going to have chemoreceptors. And we'll talk more about this in our sensory lecture after lecture 1. These chemoreceptors are detecting the levels of chemicals, hence why they're chemoreceptors. They tell us how many acids are in the cerebrospinal fluid, and that's going to be a good indication of how the rest of the body is doing. So it's literally just a dipstick just telling us, should we start to get rid of some of those acids? Should I start to increase some of the organ systems that are going to help us remove those acids in place? So these chemoreceptors are literally just detecting the pH of the cerebrospinal fluid, and that's going to let us know if the state of our body at that point. So now that cerebrospinal fluid flows, we know that as that fluid is flowing through, it's again similar in composition to plasma. We know that the choroid plexuses, as you can see here, these are the ventricles, the spaces that are filled out. You'll note that the choroid plexuses are found in all 4 of the ventricles. So these areas are going to be producing the cerebrospinal fluid that, as we saw earlier. And that flow, where that cerebrospinal fluid flows, you'll note that it follows that pathway from the lateral ventricles into the intraventricular foramen, into the third ventricle. Then it will flow down the cerebral aqueduct right in between the third and the fourth ventricle. So once it makes its way into the fourth ventricle, then it's going to make its way out in the subarachnoid space, down to the spinal cords, all the way down, and then make its way back up to the subarachnoid space. I know it looks like it's being mentioned twice, but I've got a video that will show you the flow of them. And the final destination is the arachnoid granulations, where it can make its way back into the venous system to be absorbed back into the bloodstream. So let's play this video real quick. That will show you what's taking place. So here we're just zooming in. We're going to start to take a look at the ventricles on the insides. Here, that space. And here we're looking at from the back view, you can see the lateral ventricles, third ventricle, and the fourth ventricle. Here you can see the subarachnoid spaces. These were the spaces that are filled with the cerebrospinal fluid. And we're going to point out how we get fluid to flow out to those areas. So we'll have to start with the ventricles, at which we're going to see the choroid plexus, which are present in all 4, all lit up in green. And they're going to be secreting fluid that's going to start building up in the ventricles. And that's going to create this flow that's going to move out from the lateral ventricles. I'll show you the pathway down to the third ventricle, down the cerebral aqueduct into the fourth ventricle. And then it's going to start to fill out that space in the subarachnoid space. Okay, out to the spinal cord, back to the subarachnoid space, out to the arachnoid granulations. where it's going to flow back out, back to the heart. So this is how we create that circulation. Now, this next slide shows you what happens if there's a blockage of that. And where that blockage would typically take place, typically takes place around in the interventricular foramen or the cerebral aqueduct. Any way you look at it, any blockage of that area is going to start to create a buildup of fluid. And that buildup of fluid, especially in babies, is called hydrocephalus. And this is where we see the blockage of cerebral spinal fluid, and it creates this enlargement of the brain itself. Nothing wrong with the brain tissue per se in the very beginning, but just an enlargement of the ventricles that causes that backup and expands the brain. And if you take a look at the baby's skull, we know that it's not fully fused. So because of that, you'll start to see an expansion, and this starts to pose an issue for the baby, especially when that brain when those ventricles fill up and start to compress the brain against the skull. Okay? So what they need to do in this case is they need to create a shunt. And what a shunt is basically a drainage pathway where they can lead it right into the lateral ventricles. And you'll note that that fluid now drains back out and makes its way back into the nose, back into the stomach. Why don't they just eliminate that cerebral spinal fluid? Well, baby's constantly making cerebral spinal fluid, and they need to get it back into the system. So now they have a drainage way so that it can make its way back and replenish its own fluids. So that's our case of hydrocephalus. Let's sort of take a look at the brainstem. So now we're going to work our way from the hindbrain to the midbrain over to the forebrain. So let's start with talking about our primitive function, our primitive areas first. And I call it primitive rat brain because the brainstem is really the area that's governing a lot of our primitive functions. So first looking at the medulla oblongata. Let's first start off with the cardiovascular center and respiratory center. We'll go into these when we talk about our cardiovascular lecture as well as a respiratory lecture. But the medulla oblongata is going to contain neurons that are going to tell us the state at which our heart is beating and which our lungs are working, giving us an idea that sensory information that's coming from that area to govern those areas. You'll also note that we also have what's called the decussation of the pyramids, contralateral tract crossing. You've probably heard at some point that your left hand is controlled by the right side of your brain. Okay? And then conversely, the right side of your hand or right side of your body is governed by the left side. So information crosses, any sensory information that happens in my hand crosses through to my left side, and all that efferent information starts from my left side and crosses through the right side. So the question is, where does it cross? It crosses right at the medulla oblongata. So that is what we call the decussation of the pyramids, where you see the term contralateral. Contra meaning opposite, lateral meaning from one side to another, or on one side. So contralateral crossing. If you were to take a look at, and let me just draw this easily. Let's say I have a pair of eyes over here. I've got, maybe not a pair of eyes. Let's say there's this area, an area of the brain, and we want to send information from what's happening on the left side. That's going to come down and cross through the medulla oblongata to the other side. So about 90% of the connections that you're going to be able to see will cross through the medulla oblongata. Any sensory information that's coming in as well. Let's say you pricked your hand. That information is going to flow from one side, cross through, and cross through the other side. That's where that takes place. Now looking at the midbrain, midbrain is also going to contain areas such as the substantia nigra. And this particular area is an area of the brain, and substantia nigra means black substance. And that particular area also contains dark nucleated tissue, meaning there's tissue that contains a lot of nuclei. So here we would typically see a lot of cell bodies that result in the production of dopamine. And these areas govern subconscious motor activities. So what am I thinking about subconscious motor activities? Motor meaning motion, subconscious. Can you think of any activities that are subconscious? that you do? Breathing, okay. How about actually like motion?
I move my feet.
Hmm?
Like you sway your foot all the time.
When you move your foot?
Yeah. Like, I don't know.
Like restless leg? How about something a little bit simpler? How about on your way over here? Were you thinking about how to walk? Do you have to like, okay, now I gotta move my knee, I gotta lift up my leg? No, you didn't think about them. Those are subconscious motor movements. These are things that are sort of pre-programmed, things that you learned at some point. So they've become subconscious. So these things, and even thinking about certain, and let's tie in restless leg syndrome. Restless leg syndrome, when you look at these things, these certain things such as Parkinson's disease create unwanted movements. Okay? And typically these areas, when you look at Parkinson's, you start to see that there's a lack of dopamine. So they'll start to give these patients L-DOPA, so forms of synthetic dopamine to help regulate the amount of that type of neurotransmitter. This area is also actually known as the reward center of the brain. So these are areas that are typically centered around addiction studies. They want to look at what's happening to these types of neurons that will result in somebody being more addictive or having that addictive personality. The next thing we'll look at is the cerebellum. And that cerebellum is this butterfly shape right at the very back. And in this area, by looking at this particular area, it is going to contain most of the neurons. So if you were looking at the cerebellum, it would look gray. So one thing we want to mention, gray matter. Why was it, well, let's take a look at white matter. What would make brain tissue white? I'll give you a clue. It has something to do with some fatty substance. Myelin sheathing. Myelin is white. And so if you were to take a look at where the axons are located, in the central nervous system, you'll notice, and this was a cut off of the brain right here, you'll notice that the outer layer of the brain will be gray, while the inside will be white. So white matter is going to contain the myelinated axons of the neurons, while the gray matter, and it's gray because it contains the DNA, contains the nuclei, it's typically darker, it actually contains the cell bodies, it's going to be on the outside. So in the CNS, gray matter on the outside, white matter on the inside. Now the neurons that are located, you have all these neurons and all cell bodies that are located in the cerebellum. Looking at from an afferent point of view, we have sensory information that's coming in from all portions of the body. Here you'll see the term proprioceptors. This is telling us about the position of the body, position of the joints, muscle tension. It's sending information over to the cerebellum. And then, on an efferent pathway, it's going to help. If it's sensory information saying, this is what I'm actually doing, cerebellum's going to say, this is what you should be doing. Okay? So what it's really doing is it's help maintaining quality control. And it helps balance what is the intended movement versus what's actually happening. Okay? So what's actually happening is sensory information being sent to the cerebellum. Cerebellum is going to correct that information and send it back out. So hence the subconscious skeletal muscle movement. So what you would typically see in the cerebellum is it helps maintain fine movements. Okay. So one thing I brought up with alcohol, just to kind of tie in what happened in last week's lecture. We talked about alcohol coming in and inhibiting some of the areas. And the areas that would inhibit were the cerebellum. And so if the cerebellum is responsible for muscle movement, and alcohol comes in and starts to interfere with those areas, it's not uncommon that you would see somebody that has high alcohol levels to not be able to really move as they intended. So that's why you would typically see somebody stumble or fall or just sway back and forth. And what's happening in the cerebellum with alcohol is that now we're inhibiting the cerebellum, And that's going to start to result in unintended movements, which the cerebellum is supposed to correct. So this is typically where you would see, and to give you a good example of what takes place in this quality control, is when I scan the room. So if I'm looking from one side to the next, my intended movement is to look from left to right. And what actually is supposed to happen with the brain's program is sort of this movement like this. It's not actually smooth. What the cerebellum does is it's going to correct that sort of jagged movement as I'm scanning from left to right to make my eyes move in a smooth pattern. And if you ever, and let's hope you don't, but if you ever pulled over and a cop shines a light in your eye and they want to say, I want you to just follow my eyes real quick. What they're looking for is you're supposed to have smooth movement. Your cerebellum is supposed to correct that movement from left to right. But alcohol comes in and starts to inhibit certain areas of the cerebellum. So what's going to happen is, with inhibition of the cerebellum, I don't have that quality control. So now my eye starts doing this as it moves across. And when the cop starts to see that jagged movement, they know that alcohol is involved, and that they give them a reason to suspect that cerebellar functioning doesn't seem to be working as optimally as it should. Is there any sort of inebriation? Should we test for this? So that's one of the things that they measure on this, and that saccadic movement is this right here. Is what we call horizontal nystagmus. The next thing on here that you're also looking at is a condition called ataxia, and again another case where this man has decreased cerebellar function, meaning the cerebellum cannot govern what he's actually doing. So as he's walking around, he's getting that feedback. The feedback's going back to the cerebellum, but the cerebellum cannot correct for those actions. So, let me give you another example. Has anybody ever stumbled on anything? Like if you're walking along and you stumble on a rock or something like that, what do you typically do? It's even subconscious. You don't even really realize it. You actually correct yourself before you're like, oh, wow, I almost fell. What actually helped you correct that movement? It's a cerebellum. You knew what your intended movement was to walk, but something came up and interrupted that, sent that feedback to your cerebellum, and then cerebellum says, nope, this is how you correct it. Take place back over there, correct your walk, and you say, oh, great, now I know what I'm supposed to be doing. In this case back with ataxia, this man doesn't have cerebellar function, so what he has trouble doing is actually correcting what he's trying to do, is to walk. So his neurons, his sensory neurons are saying one thing, cerebellum's saying another thing, and so he has to consciously work on positioning his body. He has to be aware of what's taking place in order to be able to walk. Thalamus and epithalamus. Main thing about the thalamus that I want to get across is the relay center. That's one thing I want to take place. The rest you guys can read on your own. But the relay center is that it relays information, any sensory information that flows in, whether it's from the general senses, touch, anywhere on the skin, pain, or anything from the special senses, from the eyes, ears, taste, or olfactory senses, actually scratch olfactory. All that information flows through the thalamus so that it can get routed over to areas of the brain that are relevant. And see these areas, lateral, geniculate, medial, intralaminar? Go ahead and cross that out. We're not really that concerned about that. But this just goes to show that areas of the thalamus relay visual information, areas relay auditory, and other areas promote sensory information flowing in. So I'm not really concerned that you guys know which lateral versus medial. I want you to just get across that sensory information flows in. But the one thing that you do know is that olfactory does not flow through the thalamus. And again, something we'll talk about in our sensory lecture. That's an exception to the rule. In fact, olfactory is actually one of our more finer senses. It's actually going to flow in a different way. So again, stay tuned for more of that when we get to our sensory lecture. The next thing I want to take a look at is the hypothalamus. The hypothalamus is going to be the very beginning of our endocrine lecture. This is where we're going to be able to start from the very beginning. And the hypothalamus is going to contain neurons that are going to be receiving information. It's going to also receive information and can send efferent information that will regulate hunger, thirst, and body temperature. It's where it all starts. It's the center for homeostasis. This is the control center. So it's going to be receiving information. It's going to then tell us how we're going to send that information back out. And the information that's being sent out is actually going to be in the form of hormones. Hence why hormones being our endocrine lecture. And so these are going to have specific part of the hypothalamus, or actually all the hypothalamus is going to contain neurons that are going to create hormones that are going to make their way to the next area. And the next area is going to be the pituitary gland. So here the pituitary gland is going to be separated by, we're going to have a posterior pituitary and we're going to have an anterior pituitary. And again, we'll get more in depth about this in our endocrine lecture, but here we're going to be seeing the secretion of those hormones. While some of the hormones are being created in the hypothalamus, you're going to get the release of hormones that are going to take place in the anterior pituitary as well as the posterior pituitary. So starting from here, back out here, being out released into those areas. And we'll get into more detail about what's taking place. So in our endocrine lectures, we'll be talking about hypothalamus to the next target, which would be the pituitary gland. And if you remember from our first lecture, when we were talking about the secretion of testosterone, the next target would be the testes in this case. And pituitary, whether it's the testes, whether it's the mammary glands, whether it's pancreas, multiple targets for the pituitary. So the pituitary is going to send out hormones that will target other endocrine cells to start producing more hormones. The next thing we're going to look at is the reticular formation. And the reticular formation isn't necessarily a particular area of the structure of the brain, but what it is just a whole network of nuclei and nerves that are all tied into sensory information. So all that information that flows in from the thalamus is going to get directed out to their respective areas. So there's going to be visual information will get sent back to the back area of the brain. If you're going to have information about motion, that's going to get sent over to the frontal lobe. If you're going to get sensory information coming in, that's going to come in more to the parietal lobe. So this is an entire network that's going to take in sensory information and route that over to where it needs to go. So the reticular formation is important because it does govern two things. And the first thing I'm going to point out here is habituation of constant sensory stimulation. And what do I mean by that? This is our conscious way of filtering out information that is non-relevant. For instance, this whole time, you've been sensing that air conditioner. You subconsciously have been hearing it this whole time. But it's not really important information to you, because hopefully you're listening to me talking. Okay? So you've tuned out, and that is what habituation is to turn off constant information that's being sent in. Your ears are always working, and they're always sending sensory information. But the reticular formation is making its way over to the inner neurons that will say, this information does not play any importance to me right now. I'm going to tune that out. So while the sensory information is coming in, the perception of it is not. It's not until I actually probably pointed out, you're like, oh yeah, it is on. I've actually come in and turned off the reticular formation for that particular sense, or that particular auditory information that's coming in. The next thing you'll see is non-specific arousal of the cerebral cortex to incoming sensory information. So let me give you a scenario where you're waking up, and however you wake up, it's sad to think that most of us probably awake to an alarm, right? I don't know how many of you actually just wake up naturally and just be like, oh, it's a great time to start the day. But let's think of like Saturday morning. I don't know if you don't work on Saturdays. You want to wake up naturally. And typically, what happens when you're waking up naturally, you might start to become slightly aware of certain things. Like you start to hear maybe a chirp that happened outside. Or maybe you noticed, oh, maybe the temperature is starting to get warm on my bed. I need to get up. Or maybe, oh, my bladder's kind of full. I need to get up. all that is sensory information that your body is perceiving. And it's routing that information up the brainstem, to the thalamus, and it's routing it to the certain areas. And some of that information is crucial. It's going to start to wake that part of you up. So it's actually involved in the whole sleep-wake cycle, where you actually start to wake yourself back up, and it's sending sensory information so that it can now alert you of what's actually going on. What's also interesting too is how many people here drink coffee? Okay. How do you guys know about? You guys know about the caffeine now? No? Okay. Well, let me tell you about what happens about the sensory information that comes in. Sensory information that comes in typically going to involve adenosine as a neurotransmitter. And adenosine comes in and starts binding to the receptors and saying, I'm getting sensory information. And as you go through the course of the day, what's happening is adenosine is binding to those receptors, and the receptors over time stop to work as efficiently because they kept receiving that neurotransmitter. It's a form of habituation, but it's what's happening with the receptors themselves. And when you go back to sleep, the adenosine that binds to those receptors, they start to not attach anymore. Why? Because the reticular formation isn't working as much anymore. It's actually shutting back off, and those receptors are replenishing themselves, and they're waiting so that they start receiving more sensory information, and once those adenosine receptors receive information, then you start to wake back up. What's interesting about caffeine is caffeine binds to those same adenosine receptors because the active site is very similar. Or the molecule that binds caffeine that binds to the receptor is very similar to adenosine. So what happens with caffeine? Now think about when you first drink caffeine in the morning, right? When you first drink caffeine in the morning, those adenosine receptors are kind of fresh. There's not much adenosine that start binding because the pathways don't happen as much in the morning. So those receptors are less likely to be bound to adenosine, and they'll take in caffeine. Caffeine is greatest when you first wake up, right? You boost up, and it starts to activate the reticular formation, and now you start receiving, and things start to ramp up. Now, over the course of the day, and you probably did this before you started class today, who here drank a cup of coffee before you started? How effective is that cup of coffee at the end of the day versus the very beginning? Not as effective. Why? Because what's happening is that all that adenosine that's binding to those reticular adenosine receptors, we've got a lot of adenosine already there that's bound to those receptors. Caffeine doesn't really have much of a place to bind. Therefore, it's not effective. So back to this whole thing where I was talking about a caffeine nap. If you want caffeine to be really effective, you just got to take a nap. Give your reticular formation a chance to rest. Let those adenosines unbind to those receptors. So what you actually end up doing, and look it up if you don't believe me, caffeine nap. It literally tells you, drink your caffeine, just pound your coffee, and of course don't pound it hot, but drink it fairly quickly and go take a nap for about 20 minutes. Because it takes about a good 20 minutes for the caffeine to make its way into the small intestine, to make its way back into the brain, and make it to the cerebrospinal fluid where it starts to make its way into the brain tissue. Because it actually crosses the blood-brain barrier. Once it starts to make its way into the brain is when you start to wake up. Because then caffeine is starting to bind to the reticular formation, and when you wake up, you'll feel super refreshed. You don't believe me? Try it one day. Take a caffeine nap. And even think about this. It also really works. I used to do this before. Was I wake up in the morning, I'd have coffee that was already made. I would make like cold brew, pound it, and I'd go back, take another 20-minute nap. And when I woke up, my heart was pounding, and I was awake. I'm like, wow, I'm ready to go. And I was like in and out of it. I was real quick, as opposed to like, just waiting to. You drink that coffee and you wait. You're like waiting like 5 minutes. Oh, now I'm finally wake up. So this is your way of getting that boost. So if you ever need to, especially if you're cramming right before next Tuesday, try a caffeine nap. Try it out. What's that?
Can you tell our bosses that work now?
Keep that secret for yourself.
You go take a nap. Hold on. Hold on, you go take a nap.
Just take a quick 20-minute nap and caffeine. Now the cerebrum is looking at the outside. So this is where we get the telencephalon. And again, being humans, this is where we're going to see the largest portion of the brain itself. You look at all the brain tissue, most of that is going to be the cerebrum. That's the outside of the brain itself. And what connects the left hemisphere from the right hemisphere is this band of white tissue called the corpus callosum. And that corpus callosum is going to have axons that are going to travel. Again, it's a white matter. It's going to allow axons that are travel from the left side to the right side. So there's a lot of connection between the left and right sides that are involved. And so what you're going to notice about the cerebrum, and again, the cerebrum being on the outside, notice how the outside is going to be gray matter, the inside is going to be white matter. Again, you'd expect the neurons to be located, or the cell bodies to be located on the outside gray matter, while you get the axons, which are myelinated, on the inside white matter. And you'll notice areas, what we call cerebral lateralization, where certain areas of the brain have more of a specific function as opposed to others. And so you'll note the left side of the brain happens to have more speech, writing, more analytics, as opposed to the right side, which has more visual spatial tasks involved. So things such as navigation, things like geometry, things like shapes and positions, as opposed to these areas, which are more related to language. So you may have heard the term somebody might be left brain versus somebody might be right brain. And that's related to these areas. Now, how do they know that these areas exist? Well, these come to some of the earliest scientific studies. What better way to find out what this area of the brain does? By poking at it. And they used to do them on people that were awake. They used to just literally cut the brain open, expose, cut they would, I don't think they would cut any of the meninges, but they would come in and start poking areas. And they would say, okay, well, this area, I want you to count from 1 to 10. 1, 2, 3, 4, 5, and they start poking at that area. And they start poking at that area, it starts affecting their speech patterns. And they'll just notice, yeah, I could think the numbers, but I just couldn't say it. Well, so that area must be speech. Start poking at this area, and all of a sudden, their ability to hear information starts to decrease. So this area must be involved. Start coming in and start messing with this area, and they start saying, oh, now the right side of my vision starts to get faded, and that area must be related to vision. So they start to notice that these areas have very specific functioning. In fact, it's not like this area is the only area involved. If you look at speech and language, you know that anything that's related to speech has to travel to that area for language comprehension. Typically, if you're listening to me talk, there's a lot involved. It's not just language comprehension, speech, it's being able to look at a language center and relate that to areas of the brain that have that area stored. So information is traveling back and forth, not only in between, not only on one side of the cerebrum, but also in between the hemispheres. And that's what the corpus callosum does, is it allows information to travel back and forth. And I'll talk about the pathways that lead to. Now, there is an issue with people with certain types of seizures, and these are fairly severe seizures, where one of the last measures that they can do is they can cut the corpus callosum. Because what they find about seizures is that you get a lot of information and a lot of, I would say, nonsensical, extreme electrical activity that happens on both sides, causing seizures to take place. And what they can do to prevent some of the seizures is cut the area to prevent seizures from traveling from both sides. And that typically will mitigate the amount of seizures taking place. So these areas where they cut the corpus callosum can now prevent information from traveling from one side to the next. So the things where we mentioned earlier, left brain controlling the right side, that information can't travel to the other side. So it's not uncommon for people that have this what's called split brain, because we've cut the corpus callosum, to have almost two independent minds working. Yes?
Is that why with the stroke they have problems with speech and comprehending certain things?
Yes, certainly. Because areas of damage, well, depending on where that stroke takes place, can start to affect those areas.
So when they split it, are they still like a vegetable, or are they still?
You want to see what that looks like? Yeah, got a video for it.
Oh.
So this is an old video, but obviously you can tell by the equipment that they're using. But they're watching a guy who actually had his corpus callosum severed due to epileptic seizures. And what they end up doing, I'll just show you the video. I'll just kind of cut to, because it's a 10-minute video and I certainly don't want to play the entire thing.
We began our journey into the human brain here on the campus of Dartmouth College in New Hampshire.
You.
Scientists Mike Gazan storms that caused his seizures. But it also prevented the left and right halves of his brain from communicating with each other. In the years since the operation, Joe's epilepsy has been under control. He now earns a living at an egg farm, and in his everyday life, he's largely unaffected by the fact that his left and his right brains work independently.
Do you feel any different when you think about something that you did any differently from the way you felt before the procedure?
It's just been a backup brain, that's all.
That's something everybody could use, right?
I found out how true that was right away when I was asked to draw a different shape with each hand. In a brain like mine, roughly speaking normal, at least all in one piece, the left half of my brain controls the right side of my body, while the right brain controls the left side.
Oh, no.
But because the two halves are connected,
Nothing wrong with that.
getting each hand to work independently isn't easy.
Well, we're seeing that the fact that Alan's hemispheres are connected, and that the motor messages from one are confusing the motor messages in the other.
I was just drawing an upside-down duck.
Okay. But when Joe is given the same task, his two hands operate as if controlled by two separate brains. What's happening is that each half of Joe's brain is given a separate instruction. He's asked to fix his eyes on the cross in the center of the screen. Anything flashed to the right of the cross goes only to his left hemisphere. Things to the left go to his right hemisphere. Because the two don't communicate, each hand does only what its half of the brain sees.
Wow. It's really like two different people doing the same.
That's right.
Same task.
That's the idea. Okay, Joe, I want you to keep your hands up.
In an experiment that's now a classic in brain research, Mike Gazzaniga over 30 years ago used a similar setup to find out if the two halves of the brain are specialized to do different things.
Shit.
Joe is being flashed a word only to one half of his brain. Words flashed to the right
Storm.
are seen only by his left brain, and Joe can report seeing those words just fine.
Handle. Good.
But when a word is flashed to his right brain,
Didn't see that. Okay. So I'm going to ask you
but now watch what happens.
to draw that with your left hand.
More visuospatial. He wasn't able to verbalize it.
I'm lost. Why don't you try drawing another picture of it over here if that'll help you. Awful. Oh, okay.
It's almost as though somebody has given him a secret communication.
That's right.
Now he knows that it's a telephone. Like, up until then he was blind to it.
Exactly.
When Gazzaniga first did this experiment, it instantly proved that the ability to speak resides almost exclusively in the left hemisphere. Not until he sees what his right brain is drawing is Joe able to name it.
He said church, didn't
After looking at the picture.
he? But he had to figure it out about as long as we did. That's really interesting. It's a picture here of somebody communicating almost with another person.
The communication is not occurring inside the head, it's occurring out on the piece of paper.
Yeah.
Blob. Really don't know. You want to draw a little bit more?
So far, Joe has been seeing only one word. Things get even stranger when he's flashed two words, each to only one half of his brain.
The right hemisphere saw toad.
Yeah.
And so his left hand draws a toad.
So there's the toad.
Oh, it's a toad, right?
And this time I was able to guess what was coming.
Now we'll put a little three-legged stool in there later, or what?
Joe's speaking left brain saw stool. Saying the word lets the hand that's controlled by his right brain in on the secret.
That's great. That's really interesting. And if he had seen that with the corpus callosum intact, he would have drawn a toadstool.
Right.
Not a toad and a stool.
Right, exactly the point. I've been doing this for 35 years. Yeah.
And
It gets me every time.
Yeah, it must.
This time, instead of naming the word, I want you to point to the word.
Again, Joe sees two words simultaneously. Bell goes to his non-speaking right brain. Music to his speaking left brain. When asked to point to a picture of what he saw, he chooses Bell. But when asked why,
Okay, why'd you pick that one?
Music.
Music?
and when asked to explain,
There was music down. It was a few minutes ago. Last time I heard any music was coming from.
So that is a long video, but it goes into some of the things that he ends up going into. So what you saw was a split brain where one regional functional area of the brain cannot communicate to the other. So you can see at least the hindrance behind that, why we have the corpus callosum in the first place. So certain memories can't be associated. So any visual things that he can't see might not be able to even really vocalize what it is.
And he has split personality.
What's that? I don't know. So looking at the cerebrum, you start to see different areas of the brain. I'm just going to kind of whip through these. The cerebrum, if you take a look, is actually divided. And couple things I want to point out is why this wrinkling that's taking place that you would typically see in a brain. Well, this is why the telencephalon grows so fast. In the skull itself, it doesn't have enough space, so it starts to create increased surface area. So we start to see areas that are divided, where we're going to be able to see areas that have these fissures, which are going to be called sulcus or sulci. And here I'll have all of them defined for you. And areas that are prominent folds are going to be called gyruses or gyri for plural. So we're going to start to take a look at areas of the brain that are divided from the frontal lobe, parietal lobe, and they're all divided by main anatomical features of the brain. So the central sulcus is going to start to divide some of these areas. You're going to see the occipital lobe towards the back, temporal towards the medial sides of the brain, and the frontal lobe in the very front. So with that, we'll be able to take a look at some of the functions. The frontal lobe is going to contain areas of the frontal lobe. When we look at it is mostly involved in, you'll see areas for emotion, but you'll also see motion and motor control. So these areas you would look at that we define right by the central sulcus. The most posterior portion of the frontal lobe is going to be called, where am I? The precentral gyrus. So these are going to contain the motor neurons, meaning that these are going to contain areas that are going to be tied into areas for motion. And this area, the parietal lobe, the more anterior portion, is going to contain, and this is going to be called the somatosensory area. This is somatosensory. And this is primary motor. Somatosensory is going to contain neurons that's going to be receiving information about the body. So sensory information about the soma being body, sensory receiving sensory information. So this area will start to receive information while this area will govern movement of those areas. So one of the things that we'll talk about later on is the areas of the brain, or areas that's going to resemble the brain, and you'll be able to see that on a later slide. Areas that involve receiving the most sensory information is going to represent the largest areas of that gyrus. We'll talk about that in a little bit. The next slide I have over, I'll leave this for the very end. You don't have to see it now, but I'll leave that for the end that we can see later on. I have a video all about the lobotomy, and one of the things that they do for a lobotomy is to sever the areas on the frontal lobe to limit the amount of activity that's taking place in the emotional centers. And so they typically would do this. I'll talk about that in just a little bit. This is what's called the somatosensory motor homunculus. So here we're looking at the primary, this would be the parietal lobe, and this area would be the frontal lobe. And that's all divided by that central sulcus, right in the very center. So here it would be the motor, this would be somatosensory. And notice about the areas that resemble, or the areas that represent the areas that are most sensitive, such as the lips, the hands, the tongue, and the face. These areas contain the most number of neurons that receive information from that area. So they are going to comprise the biggest slice of that gyrus itself. Areas that receive the least amount of sensory information. So things like the hip, things like the teeth, gums, and maybe not teeth, gums, and jaw. Looking at the elbow and the arm. Those areas don't receive as much sensory information, so they're going to have the smallest slices of the motor homunculus. So what you see that's drawn on the side is the areas that represent those areas of the body from receiving sensory information. Now similarly, on the primary motor, again, the more posterior region of the frontal lobe is going to contain the same neurons that are going to be responsible for motion. So these are going to contain the neurons, the cell bodies for what's called the upper motor neurons. These are going to be neurons that are going to travel down. They're going to travel down to their respective areas. So areas that require the most muscle control are going to contain, again, the largest sections of this brain slice, okay, of this gyrus. So areas like the hand, which requires a lot of motor control, lips, tongue, all that, all responsible for speech, facial muscles. So face and hand have the most motor control, so you're going to see more neurons of those areas. Areas such as the knee is going to represent a very small portion, because either the knee can flex or it can extend. It's not really much. Yeah, sure, there might be bigger muscles, but less control required from the cerebrum itself. The other area is occipital lobe. That's going to be for vision. Insula, typically for memory. Insula would be more the inside of the brain itself. And I'll leave you guys to these. Cerebral white matter, again, taking a look at the white matter itself. Cerebral white matter is just looking at the axons. So this is not the gray matter, which is the outside. The white matter is going to be the axon bundles themselves. And if you take a look at the axon tracks, these are things that are traveling from one side of the brain to the other, or traveling within the same hemisphere. These are interneurons that are starting from one neuron and targeting another neuron. So these neurons, these tracks of nerves or axons can all be labeled as three types of tracks: association tracks, commissural tracks, and projection tracks. Association tracks are just things that travel on the same hemisphere but to different gyri. So same side, just traveling all throughout from one side to another. Now commissural tracks travel from one gyri and to the different hemisphere. So naturally, these are going to have to cross through the corpus callosum. So when that guy saw earlier, when he saw a picture of it, he saw the word toad, it needed to travel through the other hemisphere so that he can actually visually see it. So the last one would be the projection tracks. That's going to start from the cerebrum and travel down the brainstem out to the spinal cord. So these are going to project further back out. So each of these you would typically see, and here you can see some of the track bundles of where they go. Commissural, traveling through the opposite side, through the corpus callosum. So here the corpus callosum, you would typically see projections back out. Projection tracks that travel down the brain, and then association tracks that travel from the same side. The last one is the basal nuclei, and looking at these are going to be responsible for voluntary movements. The basal nuclei are just, again, clusters of neuron cell bodies that are located within the brain itself. And if you were to cut and look at this transverse slice, you'll see these prominent features right here. And that's exactly what the basal nuclei are called. It used to be called basal ganglia, but now the technical term is basal nuclei. And these are really involved in voluntary movement. So things like that you're in direct control of. We'll finish up with visualizing the brain. The last thing I want to leave with is, if you guys are particularly sensitive, and this is my disclaimer, if you guys are particularly sensitive to watching some of these procedures, this one isn't necessarily gory per se, because it's a really old video, but this is what they used to do for lobotomy. So if you feel uncomfortable watching this, it's not a very long video, I think it's like 3 minutes, but it's what they used to do for people with certain mental diseases. Is they used to, before they even knew any better, was to find a way to actually punch a hole into the brain, into the platform itself, and sever areas of the frontal lobe. So this one they call with. This was actually done by back in the 40s and 50s when they used to do lobotomies. And this is an example of transorbital lobotomy where they were able to go in through the eye socket and sever certain areas. And so what they did as a form of psychiatric treatment was to cut these areas. But unfortunately, while it was able to maybe quote unquote cure their psychosis, it resulted in a lot of other adverse events, things such as a loss of personality, loss of motor control in some areas. And so in this time, they only really knew the shape of the brain, and they knew they just needed to cut those projection tracts and cut some of those axon bundles. What they would do is they knew where the positions were, so they took a needle and they would literally inject it in and just know how to spatially, where that area they needed to cut was. Let me just play the video and you guys can see how that's played out. We're done with the lecture at this point, so if you want to pack up, if you feel like going, that's perfectly okay. If you're interested in wanting to watch the lobotomy, then stick around. Again, not very long, but a little gruesome.
The hand with the fingers extended demonstrates in 3 dimensions the course of the fibers from the thalamus to the frontal lobe. The thalamus is represented by the wristwatch. The fibers to the motor area go upward like the thumb to the convexity. Those to the frontal pole run forward like the second and third fingers, while those to the base curve around the anterior horn of the ventricle.
What's interesting
like
was
the fourth and fifth fingers.
The Portuguese neurologist that studied this and won the Nobel Prize back in
Sever the fibers to the frontal pole by the lateral and medial cut, and then to sever those to the base of the frontal lobe by elevating the handle of the instrument. The connection between the thalamus and the frontal lobe are clearly shown in this illustration from Flechsig's monograph on myelinization of the infant brain. The projection pathways from the thalamus to the occipital and temporal lobes are well myelinated, as well as those to the frontal projection. Beyond the anterior horn of the lateral ventricle, the radiation bends rather sharply toward the midline and a sort of elbow. It is the aim of transorbital lobotomy to cut across this tract of fibers close to the elbow. Turning now to the operation itself, very little preparation is necessary for transorbital lobotomy. This patient came to the hospital this morning after breakfast, and if all goes well, she will leave tomorrow afternoon. The operation can be done under any general anesthetic, but electroshock is preferred because of its familiarity to the psychiatrist. Transorbital lobotomy is performed during the stage of post-convulsive coma. The electrodes are applied and the first shock is given.
So they're giving ECT, electroconvulsive therapy, shock that area.
The convulsion lasts about 40 seconds. When the patient shows signs of returning consciousness, a second convulsion is administered. Usually 3 successive convulsions are necessary, but in old people a single one may be sufficient, while in a sturdy young person 4 or even 6 convulsions may be administered without danger.
And here they're just triggering their seizures to take place. They still do ECT, but they obviously have very refined the procedure where it's
Now
not
that the
causing
convulsion
major
has
convulsions.
subsided, the nurse holds a towel over the nose and mouth of the patient. The operator lifts the upper eyelid, inserts the leucotome into the conjunctival sac, and aims it parallel with the bony ridge of the nose. He drives the point through the orbital plate, and at a depth of 5 centimeters, swings the handle far laterally.
Or no? Okay,
He
let's
then
say
returns the instrument to a slightly oblique position, still parallel with the bony ridge of the nose, and drives it 2 centimeters further.
It's why they promote the seizures in the first place, so that they're kind of unconscious.
Has there ever been like when they accidentally wake up?
Steadying the patient's head,
Probably.
he then moves the handle of the instrument about 20 degrees medially and 30 degrees laterally. In this latter position, he strongly elevates the handle of the instrument, often fracturing the orbital plate. And then finally returns the instrument to the parasagittal plane. The operation on the left side is seen from the profile view, which best illustrates the deep frontal cut.
Do the other side. Yeah, they do.
Oh, she did a box.
So they're not severing the eye, they're just getting right above that space. And it's funny because they considered it sort of an outpatient procedure.
This outpatient? They're doing the clinics?
It was like out the next day, pretty much.
There's clinics.
Obviously very controversial, it became more controversial, and obviously they stopped doing these.
Do these people volunteer to do this, or?
I don't think they volunteered to do it. I think it's more this sort of clinical course of treatment, and they just let them know that, you know, we don't have any other options for you other than a lobotomy, and it's really just.
It will be noted that the instrument
risks,
upon
the benefits
removal
outweigh
appears
the
clear
risks.
and shiny, but in view of its contact with the skin of the lower eyelid, different instruments are used for operation on the two sides. In this second patient, after operation, there is no damage visible.
Well, thank you for your guys' attention. Thank you for sticking around. I will see you guys on